Hello, this is our presentation on schizophrenia disorder for Exploring Mental Health and Developmental Disabilities class at UIT by Katelyn Wallace, Meagen Pletch, and Katelyn Matte. So during this presentation, we're going to talk a bit about the background of schizophrenia disorder, why it's important, and also describe some of the subtypes used in its diagnosis. Next, we'll talk about characteristics and symptoms, causes, and interventions for treating this disorder. We're going to present a recent research study on electroconvulsive therapy as one of the treatment options for schizophrenia and critique the article. And finally, we will present some ways that schizophrenia is portrayed in society. So what is schizophrenia disorder? It's a long-term severe mental disorder which is characterized by a variety of psychotic symptoms, including but not limited to disorganized thoughts and behaviors, hallucinations, and delusions. At least one person in 100 can be expected to develop schizophrenia. Men and women are affected equally. However, men are more likely to experience their first psychotic episode in their late teens or early 20s, while women usually develop symptoms in later years between 25 to 35 years of age. Even though its prevalence is quite small in the population, schizophrenia actually accounts for 1/4 of all mental health costs in Canada and takes up 1 of 3 hospital beds in a psychiatric unit. Because of its cost to society, it's important that resources and services in the community settings increase their support for this disorder outside of the hospital, with the goal that individuals can help maintain their illness on an outpatient basis in order to decrease the burden on the hospital system. So in this next slide, we're going to talk a bit about the subtypes of schizophrenia that existed in the Diagnostic and Statistic Manual 4, or the DSM-4. In this version, schizophrenia was divided into 5 main subtypes that could be diagnosed. However, the new DSM-5 that came out in May of 2013 no longer identifies subtypes. So in the past, subtypes have been defined by the predominant symptom at the time of evaluation. However, a person's symptoms can often change over time and may present overlapping symptoms from different types. So because most health services may still be using the DSM-4 criteria in their practice, we're going to take a minute to describe some of these subtypes anyways for your own knowledge. The first subtype is paranoid schizophrenia. And the defining feature for this subtype is the presence of auditory hallucinations or prominent delusional thoughts about persecution or conspiracy. So for example, the person may believe that the food they're being served in a restaurant has been poisoned, or that a person on the TV station is talking to them, telling them to hurt someone, or telling the individual to hurt themselves. People with paranoid schizophrenia may be more functional in their daily lives, such as the ability to go to work and engage in relationships, than those with other subtypes of schizophrenia. And the reason for this may be that people suffering from this subtype often do not exhibit symptoms until later in life and often have achieved a higher level of functioning before the onset of their illness. There is a broad spectrum to the nature and severity of symptoms that may be present at any one time. When symptoms are in a phase of exacerbation or worsening, there may be some disorganization of thought processes. At this time, people may have more trouble than usual remembering recent events, speaking coherently, or generally behaving in an organized, rational manner. While these features are more characteristic of other subtypes, they can be present to differing degrees in people with paranoid schizophrenia. Depending upon the current state of their illness, supportive friends or family members often may be needed at such times to help the symptomatic person get professional help. Next, disorganized schizophrenia is defined by disorganized speech and behavior, odd mannerisms, and grimacing. Delusions and hallucinations in this subtype are less prominent than in paranoid schizophrenia. These individuals may have significant impairments in their ability to maintain normal activities of daily living. Routine daily tasks, such as dressing and bathing, can be significantly impaired or lost. Catatonic schizophrenia is characterized by severe motor disturbances. Affected people may exhibit a dramatic reduction in activity to the point that voluntary movement stops, called catatonic stupor. Alternatively, activity can dramatically increase, a state known as catatonic excitement. Patients may exhibit an immobility or resistance to any attempt to change how they appear. They may maintain a pose in which someone places them, sometimes for extended periods of time. This symptom sometimes is referred to as waxy flexibility. Some patients show considerable physical strength and resistance to repositioning attempts, even though they appear to be uncomfortable to most people. Residual schizophrenia would be diagnosed when the patient no longer displays prominent symptoms. In such cases, the schizophrenic symptoms generally have lessened in severity. Hallucinations or delusions may still be present, but their manifestations are significantly diminished in comparison to the acute phase of their illness. And finally, the undifferentiated subtype would be diagnosed when no other presentation has dominated, and they have varying symptoms of different subtypes of schizophrenia. So just as the symptoms of schizophrenia are so diverse, so are its ramifications. Different kinds of impairment affect each patient's life to varying degrees. Some people require custodial care in hospital settings, while others are gainfully employed and can maintain an active life. However, the majority of patients are at neither of these extremes. Most will have a waxing and waning course marked with some hospitalizations and some assistance from outside support sources. People having a higher level of functioning before the start of their illness typically have a better outcome. So in general, better outcomes are associated with brief episodes of symptoms worsening, followed by a return to normal functioning. Women have a better prognosis for higher functioning than men, as do patients with no apparent structural abnormalities of the brain.
On this next slide, we're going to talk about the characteristics and symptoms of schizophrenia. The DSM-5 characterizes schizophrenia by the presence of delusions, hallucinations, disorganized speech and behavior, as well as any symptoms that cause social or occupational dysfunction. To be diagnosed with schizophrenia, there must be symptoms present for at least 6 months, with 1 month having active symptoms. At least 2 of the above symptoms that are listed must be exhibited in the 6-month period for a diagnosis of schizophrenia to be made. And it's also noted that any other mental or medical condition needs to first be ruled out before the diagnosis of schizophrenia can be given. The symptoms of schizophrenia are generally divided into positive and negative symptoms because of their impact on the diagnosis and treatment of an individual. Positive symptoms are those that appear to reflect an excess or distortion of normal functions. The list on this slide shows positive symptoms. Delusions are classified as fixed false beliefs that cannot be reasoned away. There are different types of delusions, such as grandiose, paranoid, or persecutory. Hallucinations are sensations that appear real, but are created by your mind. These hallucinations reflect distortions in the perception and interpretation of reality. They can affect any of the 5 senses. However, auditory and visual hallucinations are the most common in individuals with schizophrenia. Disorganized speech includes a variety of different terms. A person may demonstrate loose association, which is when one's thought does not logically relate to the next, or tangential speech, where the speaker wanders and drifts but usually does not return to the original topic. Bizarre behavior can be any type of abnormal behavior related to the person's clothing, appearance, social behavior, or sexual behavior. Negative symptoms are those that appear to reflect a loss of normal function. There's also a list on this slide that shows possible negative symptoms of schizophrenia. A flat or blunted effect refers to the individual's facial expression, and flat or blunted means a loss of observable facial expression. Thought blocking refers to when an individual suddenly stops speaking mid-thought, and symptoms of depression that a person with schizophrenia could experience include sadness, lack of interest or pleasure in activities, and trouble with sleeping. This next slide includes a short audio clip of what patients have explained their auditory hallucinations sound like.
You are so stupid. Look at you. No, you can't. Stupid. Poison the cars. Jump now. Jump in front of the car. Go on. Do it. No, don't. Don't cross the road. You can't. So stupid. Look at you. Stupid.
As you can tell, that audio recording was quite frightening, and we only heard around 30 seconds of it. Hopefully this gave you small insight into how distracting and possibly frightening auditory hallucinations can be for an individual with schizophrenia. If you're interested, you can find the rest of the video. It's about 3.5 minutes, and it's on YouTube, and we will include the link on our slide. On this next slide, we're going to discuss the causes of schizophrenia, and no single factor seems to be the most significant in the cause of schizophrenia. However, studies have shown that schizophrenia does have a genetic component. Relatives of someone with schizophrenia are at a higher risk for developing the mental illness. Also, stress can trigger an episode in an individual with the inherited makeup for schizophrenia. There's also research that states neurobiological factors can influence an individual developing schizophrenia. Neurotransmitter abnormalities such as excess dopamine, imbalances between dopamine and serotonin, or problems in the dopamine receptor systems in the brain can make an individual at risk for developing schizophrenia. And also not as heavily researched, developmental factors may also have an effect on causing schizophrenia. Stressors in childhood regarding trust issues in relationships can be a trigger for causing this mental illness.
Now we are going to have a look at some of the interventions used to overcome the symptoms of schizophrenia. Although it is not curable, there are a variety of interventions used to allow a client to regain a regular lifestyle. Depending on how severe their symptoms are, people with schizophrenia may be treated as outpatients or they may be hospitalized. Today, the illness is treated primarily with a combination of medication and psychosocial interventions. Counseling, for example. Family counseling is often recommended to help people with schizophrenia and their families understand and manage problems associated with the illness. It is important that they learn as much as possible about treatments being offered, understand the pros and cons of each treatment, and discuss them with the physician so everyone becomes a partner in care. There are two main categories of interventions for people with schizophrenia. They include biological treatments and psychosocial interventions. Antipsychotic medications are the main class of drugs used to treat schizophrenia, but other types of medication may also be prescribed to treat particular symptoms such as depression, anxiety, or sleep difficulties. Some examples of antipsychotic medications used to treat schizophrenia include risperidone, ziprasidone, Seroquel, and clozapine. Another example of a biological treatment is electroconvulsive therapy, which is often referred to as ECT, electroshock therapy, or shock treatment. It is most commonly seen in cases where the individual is severely ill or they are not responding to the medication as listed above. It may also be prescribed for people who are suffering depression as an illness. Psychosocial interventions help people set and achieve goals in key areas of their lives. Two examples include case management and counseling. Case managers are clinicians who are trained in psychosocial rehabilitation. They link people to agencies and services, communicate with families and other caregivers, and monitor the individual's satisfaction and progress. They address a wide range of needs to help their clients achieve the best possible quality of life within the community. Their work may include help with housing, vocational, social, educational, and financial needs, or crisis intervention, depending on the client's needs at any given time. The last example is counseling. The most common form of counseling for people with schizophrenia is supportive psychotherapy, which can be provided individually or in group formats. Using this approach, people learn more about the sources of their distress and receive help to change beliefs and behaviors that contribute to their problem. Emphasis is placed on encouraging people to develop their strengths and their ability to cope with illness. Interventions for family and healthcare providers include creating a routine with the client, avoiding unrealistic promises, teaching coping mechanisms, and being aware of the possibility of reoccurrence. Increasing self-esteem is a large factor in the recovery of someone with schizophrenia. To do this, a person or nurse can provide sincere, undivided attention. They can help a client break down large tasks into smaller steps, and they can provide positive feedback when necessary. An article that we investigated during this project is called Using ECT in Schizophrenia, a Review from a Clinical Perspective. The objective of this study was to address the use of ECT in schizophrenia, focusing on the intervention used on clients who also post symptoms of depression in the clinical setting. The methods used involved a review of data on the use of ECT in schizophrenia patients drawn from original studies indicated by the database PubMed, and a specific focus on 4 main issues: symptom response, technical application, continuation and maintenance of ECT, and combination with medication. The overall result of the study was that catatonic patients are the most responsive to ECT. Positive symptoms such as paranoid delusions and affective symptoms appeared to decrease after the use of ECT. There are indications from the study that ECT may improve responsivity to medication. The use of continuation and maintenance treatments in responders also appears beneficial. Overall, the results demonstrated that a combination of ECT with medication appears to be the preferable treatment over the use of either single treatment alone. An effective combination, particularly with clozapine, is supported by the data. In conclusion, certain schizophrenic patients may benefit significantly from the use of ECT. However, a limitation was noted from the study, and that was more specific research is required to address particular questions such as the effect of ECT on clients with negative symptoms or clients who are not also suffering from depression. So now we are going to look at how society views schizophrenia. Listed on the slide we have here are just some of the general statements about stigma that individuals with schizophrenia have to face every day. So first, individuals with schizophrenia all have the same symptoms. As mentioned, there are different types of schizophrenia as originally highlighted by the DSM-4. Because there's a vast list of symptoms for someone with schizophrenia, they may appear to be different throughout the day, and each client will appear different in the clinical setting. It is impossible to say that all people with this disorder will have the same symptoms at a given time. People with schizophrenia are dangerous, unpredictable, and out of control. A major stigma in society is that those with mental illness, especially those with schizophrenia, are violent or dangerous, when in fact they are no more dangerous than the general population. Furthermore, it has been proven that only 5% of violent crimes are committed by those with mental illness, leaving the other 95% to be committed by those without a mental illness. In addition, it also has been found that those with schizophrenia are more likely to become a victim of crime rather than those who commit the crime. Schizophrenia is untreatable. As mentioned in previous slides, schizophrenia is not curable. It is, however, treatable through interventions such as therapies and medication. And then the last 3, we can kind of combine together. So sufferers need to be hospitalized, people with schizophrenia can't lead productive lives, and individuals with schizophrenia can never regain normal functioning. The only point for a schizophrenia client to need hospitalization is when they have lost control of their daily functioning. If a client has the required support, proper housing, and proper interventions that appear to be supporting the client, they may live a happy, high-functioning life much like the rest of society. If a schizophrenia client is able to provide the basic needs of life and provide ADLs independently, there is no reason for them to be hospitalized. Schizophrenia is generally not found to be a degenerative disease like dementia, which worsens over time. People with schizophrenia are found just to have the reoccurrence of similar symptoms that can be managed with their current therapy or intervention. So I hope for some of you listening, this has kind of cleared up a few pieces of stigma that we often see in society.
So we're going to end our presentation with a final quote that states, "For too long, we have swept the problems of mental illness under the carpet and hoped that they would go away." So this speaks to how in the past and still in the present, mental illness is not talked about, and there's still a huge stigma attached to these disorders in society. It's important that we become more open with our discussions about mental health disorders in order to get rid of the stigma that these individuals face on a daily basis. So this concludes the end of our presentation on schizophrenia disorder. We hope that you learned something during this presentation and that you'll be able to use some of this information during your future practice. Thanks for listening.